Hi, everyone. Welcome back. We're going to continue our discussion on various chemotherapy drugs that you'll see used in the treatment of a variety of different cancers today. So, our topic for this session is going to center on a class of drugs called the anthracyclines. This is a very important class of chemotherapy agents. One particular drug, doxorubicin, is used in a variety of different regimens to treat patients with cancer. So we'll spend a little bit of time talking about this drug, give you a sort of an overview of the class, the mechanism, and some of the toxicities to better prepare you for understanding when we start to talk about different cancers. And these objectives are going to be consistent with what we talked about for the nitrogen mustards and alkylators. Okay. So the anthracyclines have been around for, oh, geez, 40, 60 plus years. The prototypical anthracyclines include daunorubicin and the homolog doxorubicin. And these two molecules were discovered from natural sources. You actually have microorganisms, Streptomyces species, out in the environment that have the capacity to synthesize these two very potent cytotoxic molecules. And in an attempt to improve activity, make derivatives, make the molecules less toxic, the pharmaceutical industry used doxorubicin and daunorubicin as inspiration to synthesize semi-synthetic derivatives, including idarubicin, epirubicin, and then valrubicin. Neither of those three drugs are used as often together as much as doxorubicin is being used, so they're sparingly used at best. As a class, you'll see that all of these molecules contain a tetracyclic conjugated ring system. So it's a flat or planar tetracyclic system. And attached to that tetracycline system is a sugar residue, a donosamine sugar residue. When you take the sum of the sugar residue and the tetracyclic ring system, what you end up with is a molecule that's capable of doing a couple things in a cell. The first thing it can do by virtue of the planarity or the flatness of the ring system is an intercalation event. So remember, intercalation describes the ability of something to slip in between two opposing objects. The opposing objects in this scenario are going to be DNA bases, which they themselves are planar, i.e. flat, and the doxorubicin or daunorubicin planarity allows the drug to slip in between bases of DNA. So these molecules can intercalate DNA, and when they do so, they create a situation which makes it very difficult for polymerase enzymes to replicate DNA, to unwind DNA, or to express the DNA for the purposes of making RNA. Right? So transcription is reduced and DNA replication is reduced. And that's all because of intercalation. Now, while that might account for some of the action of the anthracyclines, probably the most important mechanism to help describe its cytotoxicity ends up being the ability of the drugs to inhibit human topoisomerase 2. So on the right side of the screen, you see a sampling of the molecules, doxorubicin and daunorubicin in particular. And then we have idarubicin, valrubicin, and epirubicin. And as you survey those structures, you'll see that they all have this tetracyclic system, 1, 2, 3, 4. And the latter three rings in particular contribute to the planarity or the flatness of the molecule, allowing it to intercalate the DNA. And then they all have, whoops, excuse me, they all have this donosamine sugar residue that's attached to this A ring that we'll describe in a minute. So what you end up seeing is, for example, in epirubicin, this area is going to intercalate this area here is going to bind to topo 2. And then the ring here, the sugar residue, is actually going to bind in the minor groove and actually establish an electrostatic interaction between the negatively charged phosphate backbone in DNA and the amino group in that donosamine sugar. Okay? So when you add up the structural elements that I just described, you get intercalation to decrease RNA and DNA synthesis, and then you get this inhibition of topoisomerase. What do we really mean when we say inhibiting topoisomerase 2 in particular? Well, remember, topoisomerase 2 is an enzyme in our cells that catalyzes the formation of transient double-strand breaks. The enzyme intentionally cuts the DNA on both sides to help relax the DNA and open up the DNA so we can get some strand passages occurring. And it facilitates replication. Now, the important thing about topoisomerase 2 is that after it induces those double strand breaks, it fixes those breaks. It reseals those breaks in the DNA. Okay? It cuts it, allows the strand to pass, and then it fixes it. What's interesting here is that when you administer doxorubicin to a patient with cancer, the doxorubicin will travel to the cancer cell, get into the nucleus, and then when the topoisomerase enzyme binds to the DNA and cuts that DNA, a drug like doxorubicin can slip in and bind very, very close to where that cut occurred, and it will inhibit topoisomerase 2 from resealing the break. As a result, what you end up with is an increase in the frank number of double-strand DNA breaks. And what do we think that's going to lead to? Well, hopefully the quantity of breaks that have been introduced overwhelms the cell's ability to repair those double-strand breaks. And what we like to see is apoptosis occurring, right? That's desirable. I would be remiss if I did not mention that a drug like doxorubicin and all the other anthracyclines have the capacity to increase the formation of reactive oxygen species. These drugs get into the mitochondrion and they allow for some reduction reactions to occur. They serve as substrates for reduction reactions, and in doing so, you increase the amount of superoxide that can lead to the formation of a variety of different oxidizing agents, including the hydroxide radical. And the formation of these reactive oxygen species can actually lead to cancer cell death as well. We see some membrane effects. These drugs can lead to the oxidation of the lipid membranes, contributing to perhaps the cytotoxic effects. Right? And there's probably mechanisms that we're not even aware of that these drugs participate in. So here's an example of what I was describing when I was talking about intercalation. That area that I just circled represents that flat ring system, the B, C, and D ring. And the B, C, and D ring is going to be able to slip right in between two bases in the helix. And then you can see the donosamine sugar, and then another portion of the molecule kind of sticking out there in the groove. Right? And then if you were to grab onto the top of this slide and sort of pull it towards you, what you'd be doing then is looking straight down through the helix, and you can see again, this area is intercalating the DNA. Then the A ring, which is right here, right? The A ring has the sugar residue. And here's the nitrogen. And that donosamine sugar that is going to interact with phosphate backbone. And together, that's going to lead to an increased affinity of the drug for the DNA. And then when the DNA has been cut by topoisomerase, that essentially creates the binding site for doxorubicin and other anthracyclines with regard to the inhibition of topoisomerase 2. And that's depicted here on the right side. So over here, you can see that the DNA is represented on the left, and then the right side is going to represent where the topo 2 enzyme would be. And you can see the drug in the middle. And there's this -1 base pair, and then there's a +1 base pair up here. And really, that's just indicating where the break has occurred. And doxorubicin and anthracyclines tend to bind and intercalate around this -1 base pair, right by where the break happened. They intercalate. And in addition to intercalation, they H bond to residues in the topoisomerase enzyme. So you can see a serine residue in topo 2 is H bonding to doxorubicin. This threonine residue is H bonding. And likewise, this glutamine is H bonding to the alcohol coming off the side chain of the A ring in doxorubicin. So from a structure activity perspective, I'm not really going to spend too much time on this. Again, too, I've already alluded to the fact that the B, C, and D ring end up being important for binding the DNA. The A ring here, again, is important for contributing to interactions lending to affinity for topo 2, as well as a variety of other interactions. And then the sugar residue here is going to be positively charged at physiological pH. So the negatively charged phosphate backbone can interact with that sugar residue. And keep in mind, doxorubicin, like all chemotherapy drugs, carries with it liabilities. And the liabilities, structurally speaking, with regard to doxorubicin and other anthracyclines, rests with the C ring and the carbonyl group coming off the A ring. This particular portion of doxorubicin is called a quinone. And then, of course, this is just a carbonyl group. But the quinone can get essentially reduced to the hydroxy quinone, and that can have bad effects, especially with the heart. And this carbonyl group can get reduced to an alcohol, and that actually can have negative effects on the heart as well. And we'll talk about that in a second. So, anthracycline toxicities. Anthracyclines, being chemotherapy regimens or chemotherapy drugs, have the same similar pattern of adverse effects as the other chemotherapy drugs we're going to talk about. Myelosuppression, it's going to decrease the amount of the myeloid lineage that we have available to fight off infection. So people are probably going to be myelosuppressed and at increased risk of opportunistic infections as well as a variety of other infections. Nausea, vomiting, and diarrhea, not surprising. That's an adverse effect of anthracyclines and pretty much all the other chemotherapy drugs that we'll talk about. The conjugated ring system seen in the anthracyclines increases then the likelihood that a patient could get burned secondary to sunlight or UV exposure. So photosensitivity becomes a concern. And then fluid discoloration. If you look at anthracyclines like doxorubicin, those of you that have worked with doxorubicin, if I ask you what color it is, you'll say red. Doxorubicin is called the red devil. And this red hue that is associated with anthracycline as a result of its structure actually can discolor, say, your tears, your sweat, and even your urine for that matter. So patients who receive anthracyclines like doxorubicin might notice fluid discoloration, and that could be somewhat concerning or alarming considering what's going on with the patient. But a lot of times it's just an unfortunate adverse effect of the drug. So those are some of the usual and customary adverse effects that you would see with anthracyclines. However, the more concerning adverse effects are related to the heart and the cardiovascular or cardiac toxicities. The majority of the cardiac toxicities seen in patients receiving anthracyclines stems from the drug's ability to generate free radical formation. Now, remember, I said free radicals can contribute to the anti-cancer effects of this class of drugs, but when we start to look at what goes on inside a cardiac myocyte, it becomes a lot more concerning. Free radicals get formed in cardiac myocytes, and that can wreak havoc and damage and lead to apoptosis in the cardiac myocytes, ultimately producing uh, the risk of heart failure in patients receiving anthracyclines. And usually, when we start to overproduce free radicals, most of the cells in our body have the capacity to scavenge those free radicals. They have enzymes in place to eliminate or neutralize the radicals. However, when we look at cardiac myocytes, they have diminished capacity to do so. We'll look at an example of that in a minute, but largely it just relates to a suppressed supply of superoxide dismutase and catalase, such that peroxide can get converted to the hydroxide radical. One other interesting mechanism of cardiac toxicity stems from anthracycline's ability to lead to calcium overload in the cytosol of the myocytes. When a drug like doxorubicin gets reduced by a particular dehydrogenase enzyme, what you end up forming is a byproduct or a metabolite called doxorubicinol. And that can actually interfere with the cardiac myocyte's ability to pump calcium back into the sarcoplasmic reticulum. And we'll look at an example of that in a second. These are very, very concerning. These are dose-limiting toxicities. Again, we don't want to do more harm than good by giving a drug, so we have to have strategies to mitigate the toxicities associated with anthracycline administration. And one thing that we can do is we can monitor and limit the amount of anthracycline that any one patient gets in their lifetime. And the guidelines have established maximum lifetime doses for anthracyclines. Somebody who is getting doxorubicin to treat their first cancer, let's say, once they start to approach 450 to 550 milligrams per meter square total, that's about it. We don't want to give them any more doxorubicin once we hit that 450 to 550 milligram per meter square mark. So the cumulative dose is what we watch for, not per cycle, not per, say, cancer, not per treatment course, but total. If a patient got treated initially with doxorubicin, we would add up the total milligram amount that they got per metered square. If they had a recurrence of that cancer years later, we would, and we wanted to use doxorubicin in them again, we would look at where we stopped and we'd start right there. And we wouldn't exceed that 450 to 550 milligram mark. We don't want to do more harm than good. And then here are the other established maximum lifetime doses for some of the other anthracyclines. One other strategy might be to use an agent called dexrazoxane, which is a iron chelator. Iron is a culprit in this free radical formation toxicity. And if we can eliminate the preponderance of iron in a particular area, we might actually be able to suppress the formation of some of these free radicals. But really, how does all of this work? Let's look at this production of radicals leading to cardiac myocyte damage first. I already highlighted the presence of this quinone on the C ring in a drug like doxorubicin. And as doxorubicin gets administered to a patient, it can slip into a variety of different cells throughout the body. It might end up localizing in the mitochondria of the cardiac myocytes. And when it gets into the mitochondria, what can happen is that quinone can actually get reduced to the hydroquinone, as I suggested earlier. And CYP450 reductase, NADPH CYP450 reductase, is the enzyme that's responsible for converting the quinone to the hydroquinone. Okay, fine. What happens though is during that reduction reaction, the cell is ultimately going to produce the superoxide radical from oxygen. Okay, fine. Some superoxide radical got formed. Well, our cells have enzymes to address the presence of that radical. Superoxide dismutase is an enzyme that is capable of quenching superoxide radicals and converting them to peroxide. Now, peroxide by itself carries with it liabilities. It's dangerous because if it comes apart, it can generate radicals. However, guess what? Our cells have an enzyme called catalase, and catalase is responsible for converting hydrogen peroxide into oxygen and water. So this is a very nice, elaborate system whereby the cells can detoxify superoxide radicals. Now, what if I tell you that the heart, the myocytes in the heart in particular, have decreased superoxide dismutase and decreased catalase? They don't make a lot of it. They don't make much of it at all. So what is going to end up happening, you guys, is as this quinone gets reduced to the hydroquinone under the direction of CYP450 reductase in the mitochondrion, superoxide radicals are going to accumulate. Now, superoxide radicals can get quenched by a little bit of superoxide dismutase that the cardiac myocyte might make, but this radical can go out and start to cause damage. If some of this superoxide radical gets converted to hydrogen peroxide because we had a little bit of dismutase available, great. But we've made peroxide now. And since the heart doesn't make a lot of catalase, we're not going to go this direction. What we're going to end up seeing is ferrous iron donating essentially an electron to peroxide. And in doing so, it's going to convert itself to ferric iron. And we've then just produced the hydroxide radical and then the hydroxide anion. And just like superoxide radical, the hydroxide radical can go and damage the cardiac myocytes as well. Okay. So the production of reactive oxygen species is largely responsible for damaging the heart. Also inside the mitochondrion, or the mitochondria in the heart, as the mitochondrial membrane gets damaged secondary to the production of all of these radicals, the mitochondria will release something called cytochrome C. And if you remember back, cytochrome C is a very potent inducer of apoptosis. We don't want apoptosis in our cardiac myocytes. We want it in the cancer cells. When this pathway happens in the cardiac myocytes, we're going to cause cardiac damage, decreased cardiac function, a decreased ejection fraction. So we need to monitor the patient's ejection fraction at the onset of therapy and during therapy while they're getting an anthracycline. Briefly, doxorubicin can get metabolized by an enzyme in the body called aldoketoreductase. Aldoketoreductase will take the carbonyl group coming off the A ring and reduce it to an alcohol to generate something called doxorubicinol. And doxorubicinol has the ability to inhibit the cardiac myocytes' ability to repurpose calcium back into the sarcoplasmic reticulum. So if this is the sarcoplasmic reticulum, for example, right, inside a cardiac myocyte, when an action potential signals in the cardiac myocyte, there's a receptor embedded in the sarcoplasmic reticulum called the ryanodine receptor. And through the ryanodine receptor, calcium will get released. And when calcium gets released, calcium will ultimately go and interact with contractility elements, the sarcomeres, and it'll cause the sarcomeres to shorten or to contract. Okay. Then we have another sort of protein or pump embedded in the surface of the sarcoplasmic reticulum. And this pump is called a SERCA pump. It's a sarcoplasmic reticulum calcium stimulated ATPase or something like that. I can't remember what the acronym actually stands for anymore. I'm getting too old. But what I can tell you, though, is that the function of the SERCA is to take the calcium back up and store it so that the cycle can then just keep repeating and repeating. And as the SERCA takes up the calcium back into the sarcoplasmic reticulum, the sarcomeres will relax, right? Doxorubicinol may, in fact, keep the ryanodine receptor open, causing a leak, or it may actually block the SERCA, thereby keeping the concentration of calcium high in the cytosol. And this increased calcium concentration is also then attributed to some of the toxic effects seen with anthracyclines. Okay. All right. Probably more than you wanted. But nonetheless, anthracyclines, it has a mechanism of action. They intercalate DNA, and that decreases RNA and DNA synthesis. And that certainly can contribute to what we see mechanistically. Increase reactive oxygen species generation. That can cause cell death as well. But the primary mechanism of action with regard to the anthracyclines is going to be inhibition of topo2 beta to be specific. This ultimately increases the number of double-strand DNA breaks. And then this will lead to apoptosis. Okay. Toxicities, as we suggested, we've got nausea, vomiting, diarrhea. We've got fluid discoloration. We have myelosuppression. We've got photosensitivity and a variety of other things that can happen. But the concerning toxicity that is associated with anthracyclines is the cardiac toxicity. Right. Okay, good. That's all I have to say about the anthracyclines right now. We will continue our discussion on chemotherapy next with antimetabolites. So we will see you soon. Thank you.